Every year, 250,000 women in the world die due to complications related to pregnancy or childbirth. 4 million children worldwide don't live up to see their first birthday.
What makes this even grimmer is the fact that a vast majority of these deaths are entirely preventable. If only women were to deliver in the presence of a skilled medical attendant, or if we were to give children recommended set of vaccines that can really bring down a lot of this mortality. And it is one of the most pressing public health challenges for us as to why are people not accessing them, or why are they unable to access them.
The Indian government tried to solve this problem by increasing accessibility and creating awareness for healthcare, ranging from policies that offer conditional cash transfers upon seeking the required healthcare to information campaigns about vaccination. Most efforts focused on increasing the demand for its users.
So these sort of interventions or policies are premised on this assumption that they can, and if you incentivize them, they will. My strand of research comes in is to say that perhaps they actually cannot access these services, and the transportation cost or the time cost to get there is too high, and that's why they are not accessing these services.
The solution to this problem lies in something far more fundamental. The research looked at one such supply-side factor: roads.
When you build rural roads, what does that do to women's ability to access these healthcare services? Do they then go and actually deliver in healthcare facilities? Are kids vaccinated? So that's sort of broadly what this research is about.
However, to measure the effectiveness of roads, a large data set was required. The Pradhan Mantri Gram Sadak Yojana, which brought in large-scale connectivity for about 14% of the rural population, became a good starting point to look at this data set. Intuitively, the strategy would be to compare a village that gets a road with one that doesn't. But realistically, roads are complicated. A village could get a road due to a bunch of different factors.
There must be a reason why it gets it. So for example, let's say the income of people in village A went up. And because now people are richer in village A, they are able to, let's say, demand that a road be built. Perhaps they also demanded many other things be done. The services at the hospitals near them be improved, or that they get access to better hospitals, or these people now have vehicles so that they can reach these hospitals. Village A was selected into building a road for a certain set of reasons. There is a selection bias. These places that have roads are fundamentally different than places that don't have roads.
Under the PM GSY program, the government announced a fixed criteria that would select a village for road construction. If a village had at least 500 people according to the 2001 census and did not have a paved road within 500 meters, then they would receive a paved road to the nearest market.
So all of these selection issues that I was just talking about, your economic connections or your social connections, political connections, you can sidestep all of these now, because you're saying, okay, at the district level, we will just say, okay, the districts that got roads or got more roads versus districts that got fewer roads, we will compare them and we will see what was the impact of building these roads on specifically this outcome: access to pre- and postnatal healthcare for women and their children.
For this, data was taken from two levels. Firstly, road construction data was collected at the village level from the PM GSY. Secondly, outcome data on women were obtained through a district-level survey conducted every 5 years. So the road construction data at the village level was mapped to the district-level outcomes. This was done by aggregating the intensity of treatment done in a particular year.
What percentage of population in the district got roads in 2004, what percentage got roads in 2005, and so on. And that's sort of what we call quasi-random, because what we're saying is that essentially it depends on the distribution of population in the villages of that district. And that should sort of be unrelated to what really happened to the fertility outcomes or the pre- and postnatal outcomes of the women.
This difference in difference strategy brings us to two sets of findings. Firstly, road constructions lead to a significant increase in a pregnant woman's likelihood of visiting a formal healthcare facility for antenatal care or ANC, as well as for childbirth.
Increase in the rate at which women give birth at a formal health facility, that goes up by about 20 percentage points. There's a 6 percentage point increase that women will actually seek antenatal care also at a formal healthcare facility. Some of the pattern of the effects really tells you that it is about access. The fact that effects are bigger in the rainy season, the fact that effects are bigger for those who live far away from the clinic. So these definitely are effects of roads.
Institutional delivery during the rainy season is stronger as the benefit of having a paved road to the hospital is greater during the rains. There is also a significant reduction in the proportion of deliveries on the way to the hospital.
So, very tangible ways that tell you that yes, access to healthcare improved. But what about outcomes, right? We don't care about giving birth with a skilled attendant for the sake of it. How does it translate to people's health outcomes, to them actually getting access to services? And this question is particularly important in the context of India because we are all very sort of tuned to thinking that rural health facilities, the services in those are pretty bad, right? So maybe it's not really useful for people if they do reach such a healthcare facility because they're not going to get good service, right? Maybe the provider won't even be there. So what really happens when people get to these places?
The second set of findings showed us that better access to formal healthcare translated into greater utilization of healthcare services and resulted in better outcomes.
I do find that women are more likely to report that they had access to iron supplements or folic acid supplements during their pregnancy, so their access to supplements improve. After the birth, within 24 hours, they were seen by a doctor. They're less likely to report birth complications. Vaccination rates of kids improve. They improve a little bit more for girls. Then perhaps girls can benefit a little bit more from them because they were the ones who were more disadvantaged.
Looking at roads as a network brings light to some spillover effects, which shows us a more realistic idea of how roads impact healthcare.
Like earlier, the road was 10 kilometers away from me or 5 kilometers away from me, and now the neighboring village gets a road, and so the road is only a kilometer away. That should still make a world of difference for me, right? Because it's the network that matters. How far am I from the road, and not necessarily did the road come to my village. In general, if you're thinking of access to health care, these impacts in ante and postnatal care, they're sort of symptomatic, I think, of access to health care in general. That if you can now go see a doctor for during your pregnancy, you can perhaps also go see a doctor because you now have fever or you have malaria. I believe that there is a way to generalize this and say that maybe overall access to health care improved. All of these are big wins in and of themselves.
But an interesting finding is seen in terms of mortality.
Fetal mortality actually goes down. So women are less likely to miscarry, 11 per 1,000 fewer miscarriages. Infant mortality goes up. Basically, that suggests is that when you're providing healthcare to women during their antenatal period, there may be some cases where the fetus that they're carrying is less robust. That fetus without adequate health care may not have survived the pregnancy, but in this case now when the adequate health care is provided, the fetus actually does make the length of the pregnancy. But ultimately these are pretty sick babies, so they don't necessarily then survive infancy. So the infant mortality rate goes up by about as much as the fetal mortality rate goes down. So if you take these together, the fetal and the infant mortality rate, so this overall antenatal and postnatal mortality rate, so this stays unchanged.
It is crucial to recognize that deaths are merely delayed, not averted.
This is sort of like a very actionable, tangible to do for our public health system, that if kids can be supported for the longer term into their infancy, then these very hard-won gains, which are currently short-term, can be turned into long-term gains for children.